Hi, I'm Merle Diamond. I'm the managing director at the Diamond Headache Clinic, and I get the topic of more than medicine. So we're going to talk about psychological approaches to headache, what's the link between headache and depression and anxiety, and also alternative methods of treatment, including some newer therapies where we're using anesthetics to block migraines. So whenever we talk about migraine and talk about mood disorder, you have to go back historically where it was thought that migraine was sort of a neurotic disorder of women who didn't have enough to do every day. And it was often linked to mood disorder. And it wasn't until a lot of epidemiologic studies had been done that we were able to see that patients in migraine were more apt to suffer from depression and anxiety and general anxiety disorder, and patients with depression and generalized anxiety disorder were more likely to suffer from migraine. So there was this bidirectional thing that could occur, but it would be silly for us not to say that they don't impact each other at all. So headache and major depression, we know from numerous studies summarized by Breslau, who did a lot of epidemiologic work in the past, that migraine major depression association is unlikely to be a psychological reaction to the unpredictable nature of migraine, and that there are shared causes which probably have to do with neurochemical abnormalities in both conditions, and it's not related to the fact that a migraine patient simply can't cope and gets depressed because they can't control their lives. And this is just a slide that sorrow has no vent and tears may make other organs weak. So that when we're depressed, certainly a lot of other somatic complaints occur. But we also know that in depression, major depressive disorders, there's dysregulation of both 5-hydroxytryptophan or serotonin, as well as norepinephrine in the brain. And these are strongly associated with depression, but also there's some amount of dysregulation in migraine as well. And these are the key modulatory neurotransmitters in navigating how the patient perceives pain, both in their cortex and in their limbic system. And so imbalances of both serotonin and norepinephrine can explain the emotional and physical symptoms of depression, as well as in pain studies we know that dysregulation may be key to why some patients perceive pain more acutely. So when we're talking about alternatives to medications, what are some of the other approaches we can do for pain disorders, and specifically for migraine? We can do psychotherapy, and that's the reorientation of thought, feeling, or perception to the real world. So the patient works with a psychologist over a long-term period to express what's going on and then help identify different tools that they could use to change their perception. It helps patients to label their feelings, recognize that their affect is a signal for their emotions, identify what precipitates it, express those feelings, because again, when they hold it in, we know patients who have suffered trauma or other acute events, these things spill out in other places, and determine what can be done with unpleasant feelings, and then use that in a toolbox so they can take better care of themselves. So in terms of psychiatry and that approach to the chronic pain patient or the headache patient, the goal is to improve the patient's functional status and their ability to participate in life without significant pain-related interruption or dysfunction. Obviously, getting good treatment on board is really, really important, but having good tools to psychologically address their pain issues is really important as well. Always identify patients for comorbidity and substance misuse. Obviously, that co-pharmacologic therapy is important. And then psychotherapy to give patients tools to cope with, giving them coping strategies. And those, there are so many different forms that we can take. One of the most common things we do in headache in terms of psychological intervention is cognitive behavioral therapy, or what's known as CBT. It has the strongest data for managing health-related anxiety and somatic symptoms and pain. There are several variations of cognitive behavioral therapy, but there are two sort of common underlying themes when we're doing cognitive behavioral therapy. One is the cognitive therapy. So this allows the healthcare provider to identify and modify unhelpful beliefs like I'm never going to get better, I can't cope with my pain, the minute I get a headache I have to crawl into bed, and nothing will ever help. And then behavioral techniques that are helpful to alter the illness and sick role behaviors. So in somebody who basically falls apart and starts crying when they have a headache, crying increases intracranial pressure and only makes a migraine worse, so having other coping techniques, relaxation techniques that the patient can utilize. In other words, increasing their toolbox so that curling up in a ball sobbing, which may be an expression of their pain but not terribly helpful to them getting back and feeling better, are really important techniques. And some of these things are learned. So, you have a parent who has migraine, that patient may have watched my mom crawl into bed and sob because nothing could be done. And so it's really important to work on where those behaviors come from. So in summary, words are, of course, the most powerful drug used by mankind. Not only do words infect, egotize, narcotize, and paralyze, but they enter into and color the minutest cells of the brain. So, it's important to have good positive therapy roles and modifications. When we talk about mind-body therapy, there are a number of different things we can do. We can do relaxation techniques or progressive relaxation, imagery and visualization. So different types of meditative techniques can be helpful. Behavioral therapy, cognitive therapy, or what we just talked about, CBT. Having good social support. So there are migraine online support groups, some of which are very helpful to patients, helping them to access care and knowledge about different type of tools that are available for migraine. Meditation in general can also be very helpful, and then biofeedback. So when we talk about biofeedback, Dawn Marcus did a study some years ago looking at biofeedback compared to traditional migraine therapies, medications. And what she found in that study was that biofeedback could work as well as traditional medicines in many patients if they were open to it. So biofeedback is where we measure different physiologic parameters. So we might measure your breathing, your muscle tension, your hand temperature, things that we normally don't pay attention to, and record it on a computer-type screen, which can either give you visual or audio feedback. And then by modifying what you're doing, your breathing, your hand temperature, your overall relaxation, the machine will give you a positive or a negative vibe if you're going in the right direction. I always say it's meditation on steroids. It kind of gives you a lot of information, but for some people, they can use that tool. And it can be very, very helpful. When we teach patients biofeedback, they generally need between 8 and 10 sessions. Some of it is covered by insurance, which is important. But it's a tool you can utilize throughout your life, so that when you're getting a migraine, you can take some time, walk away from whatever you're doing, find a quiet area, do your breathing, warm your hands, and hopefully avoid a headache. What about acupuncture? Well, there's a myriad of different studies with acupuncture in migraine. And the reality is you can find that its utility can be anywhere between 3% and 40%, depending what you read. I think the most important experience I have with acupuncture, because we don't have really good active studies looking at just headache that are consistent, is that if you know a good acupuncturist who works a lot on headache, it can be extremely effective for your patients. What about exercise? And I'm going to present two different studies which sort of contradict each other, which happens a bit. The first study was from the physical activity and headache results from the Nord-Trondhelag health study, or HUNT. They had 46, almost 47,000 subjects in it, and they found in that study, which was published in 2008, that low physical activity was associated with a higher prevalence of migraine and non-migraine headache. And in both headache groups, there was a strong linear trend of high prevalence of low physical activity with increasing headache frequency. Contrary to that, there was a study presented that looked at exercise as a migraine preventative, and they used relaxation and topiramate as their other control groups. So there were 91 patients, 30 patients in each group. A third of them did aerobic exercises, 40 minutes 3 times a week. A third of them took topiramate, and a third of them did relaxation training, and all 3 treatments were equally effective. So I guess in my own mind, what I would tell you is I do encourage my patients to exercise. I think it is quite helpful. Obviously, exercising in the midst of a migraine attack usually will make you worse. And so we try to tell patients to have a regular routine. It builds endorphins, our own body's pain-fighting capacity, and so we do believe it's helpful for headache. How do we monitor headache? And I think here we're going to present the headache diary. And this is the one we happen to use at the Diamond Headache Clinic that my dad did many, many years ago, but it's still an effective headache calendar. Anyone who has headache today or migraines today probably knows there's about 30 different apps you can get online to monitor your headaches. But something that's really, really helpful for me as a physician is looking at the number of headache days. So I have my patients track all the headaches that they have, not just migraine or things that put them to bed, how long it lasted, how bad it was, so they give it a number from 1 to 10, some people like a 1 to 5 scale, any physical or psychological factors they think, if they think they had any triggers, what medication they took, and it's sort of interesting because some of my patients will put the time they took that medication, and that's really important in terms of how that medicine might work, and then the headache relief. And we always know we're doing a good job when there's only like 3 or 4 marks on the page, but that may not be what we see all the time. And so this can get quite complicated, but what you see most commonly if we key up, and the things I sort of instruct my patients on, is do you see a lot of stuff like as letdown headaches? So do I look and see Saturday mornings are particularly bad for people when they might be oversleeping? Hormonal days, menstrual or ovulation headaches, and then obviously food and drink excesses. So on the right-hand side of the slide are all the different foods that are at least correlated to some degree with perhaps being triggers for migraine. So at the clinic, we still give out the low tyramine diet, and certainly diet is important in about 30% of our patients, and there are a number of studies that have shown this over the years. What I'll do is I do think it's a useful tool for patients. The other part of diet that's really important is to emphasize don't skip meals, eat regularly. A migraine brain likes things when they're regular. And then what types of foods might trigger migraine, and so foods that are high in tyramine can do it. Foods that vasodilate, so nitrates or nitrites, and certainly certain alcohols as well. And these are just some examples in the next few pages. So again, fermented, salted, smoked, pickled, nitrate-containing foods, the aged cheeses, freshly baked bread with yeast, we usually let it cool off if patients are sensitive, and certain types of fava beans, broad beans, and sauerkraut can also be implicated. Some peanuts, peanut butter, and then alcohol in general. But when my patients ask what they can drink, I usually tell them clear alcohol with a fruit drink. Little tip. And then, of course, things containing MSG. And last but not least, what I think is one of the most important things is caffeine. So for me, caffeine, much like overuse of a narcotic or opioid compound, as well as barbiturates, can also cause rebound headaches, and we try to limit our patients to 30 to 50 milligrams of caffeine per day. And a lot of my patients will still use caffeine as a medicine if they don't overuse caffeine at other times of the day. What about magnesium? There's some good studies that show that migraineurs have low brain magnesium, and that by replacing magnesium, oftentimes we can improve the frequency and severity of migraine. Usually we use magnesium oxide, and you can use it orally. You can also use it intravenously for acute headache as well. So what are some of the causes of magnesium deficiency? Stress, genetics, low dietary intake. If we do excesses of caffeine, alcohol, or calcium, there are certain GI disorders where we don't absorb magnesium very well, and certainly chronic illness as well. What about riboflavin? There are a couple of studies, and this is a particular one that looked at using riboflavin, a couple hundred milligrams a day versus placebo. And over a 3-month period of time, riboflavin could reduce the frequency of migraine attacks. The next one is coenzyme Q10, another randomized controlled trial that was published in 2005 by Sandor. And it looked at the efficiency of coenzyme Q10 in migraine prevention. And again, a randomized controlled trial that was a double-blind, placebo-controlled. They had only 42 patients, and they took 100 of coenzyme Q10 3 times a day versus placebo, and the attack rate was reduced for coenzyme Q10. And then there's another study by Andrew Hershey, that looked at coenzyme Q10 deficiency in response to supplementation in adolescents in a pediatric population. That study had over 1,500 patients in it. Almost 33% were deficient. They were supplemented with 1 to 3 milligrams per kilogram per day. Their coenzyme Q10 levels improved, and their headache frequency improved. They reduced their headache frequency significantly. And more importantly, even than headache frequency, their disability was reduced significantly. And this is a nice trial. I think the biggest issue with coenzyme Q10 is that I have to take it a fairly large dose, and for some people it does give them some GI upsets. The next one is Butterbur or Petadolax, and it's sort of commonly known as Butterbur. It's also known as Petacides. In this study, there were 245 patients. This was a study done by Richard Lipton. There were 3 groups, a placebo group, a group that got 100 milligrams, a group that got 150 milligrams of Butterbur. Their attack frequency was reduced by 48% in the 150 milligram group and 36% in the 100 milligram group and 26% in the placebo group. Unfortunately, raw Butterbur contains both teratogenic and hepatotoxic components. So currently we don't recommend Butterbur because the full data on this is not clear at this point. Petadolax was a brand proven safe and approved for sale in Germany, but they also took it off the market because they couldn't repeat their safety studies, which to me means probably avoid until we have more information. All forms of Butterbur have been banned in the United Kingdom, and it's expensive. And right now, we just tell patients to avoid Butterbur. Then you'll notice that I said nothing about feverfew. And the reason I've said nothing about feverfew is because there have been many well-done, controlled, placebo-controlled trials which have never showed that feverfew is consistently effective. And it is a teratogen, so we don't recommend it in pregnant women. And I think this is an important piece because it's often made as a component of natural supplements that are used to prevent migraine. So it's really important to look at the labels and have your patients look at the labels so that they're aware of what's in there. What about some of the blocks that we're doing? We know about blocks for different type of neuralgias, but blocks have also been used in migraine and in cluster and in atypical facial pain. So SPG blocks are very interesting these days because we can now do them without having to go to an operating room. In an operating room, we worry more about infection, coagulopathy, nosebleeds, and whether or not the patient has a patent area to get through. So nowadays we can do an SPG block transnasally with a cotton applicator and 2 to 4% lidocaine. And we now have some very nice little devices that have been composed that are little catheters where we can go and do repeated SPG blocks. Patients can come in both to treat cluster and migraine. Currently, there's no real good data on the outcome from this, and I've seen recommendations from various clinics of coming in once a week for 10 weeks to break a cycle, but there's no real data supporting this at this point, but it certainly is an area of active study. Thank you.